Welcome back, class. We're going to talk about our last segment when it comes to coding and billing information. We're going to talk about DRGs. DRGs are considered Medicare. Medicare started DRGs. I think they started in 1983, maybe. And it's called if you look on the CMS website, it's going to say Inpatient Prospective Payment System. It's a DRG stands for diagnosis. Remember, ICD-10, ICD-11, diagnosis stands for diagnosis related group. It's how payers can categorize hospitalization costs in a set predetermined amount for your hospital stay. That's why it's called the prospective payment system. Payments based on the primary diagnosis. Primary diagnosis is why you presented at the hospital. If you presented, go back to the broken leg, if you presented with a broken leg, that would be your primary diagnosis. If they admitted you and they found something else wrong, that would be considered a secondary diagnosis. Also includes comorbidities, other things that could have happened that could have caused you to break your leg. Maybe you didn't slip on a wet sidewalk. Maybe you blacked out and you fell and broke your leg. Also based on age, sex, and any medical procedures that are performed. And we'll get into it in a few minutes, but on the DRG system, you've got major diagnostic categories. Within those major diagnostic categories, you've got a set number of DRGs based on body capacity or body locations or types of services within the DRG system. And within each of those major diagnostic categories, you've got either medical DRGs, which are usually what you call elective surgeries. You've been dizzy and passing out, and they decide to put you in the hospital to run some tests. Or you've got surgical DRGs, appendectomies, decide to take out your gallbladder, you need a lung transplant. Those are surgical procedures, so you're going to have those different categories, and that's why the medical procedure is extremely important. And again, they've been around since the 80s, and it's an all-payer component for non-Medicare patients. So there's the MS-DRGs, which have been generated by Medicare. Then there's AP-DRGs and APR-DRGs, which again fall into the all-payer component for non-Medicare patients. The Medicare severity, the MS-DRGs, are the system for Medicare patients. And a lot of health plans started, or a lot of payers started out using the AP-DRGs, and then some states came up with the APR-DRGs that they were using on the Medicaid patients. And now it seems like health plans, some of them do all the reimbursement, whether it's Medicare patients or not. They just tie all of the reimbursement to the MS-DRGs, or some of them use a combination. If they've got Medicare patients, they use MS-DRGs. If they have Medicaid, they may use APR-DRGs. If they've got commercial business, they may use AP-DRGs. And then over here, you've got DOD and TRICARE, and they've got TRICARE DRGs. So there's a lot of DRGs floating around, but they all work off a similar concept. It's the diagnosis and the procedure codes that are driving those DRGs into major diagnostic categories, and also whether they are surgical or medical DRGs. There are some long-term care DRGs. They have a prospective payment system, and it's MS-LTC, long-term care DRGs. And typically you think of long-term care, assisted living type facilities. And what happens at discharge, the DRG is assigned based on the primary diagnosis and up to 24 secondary diagnoses. So again, you have primary, which you present with when you're admitted. You've got secondary, comorbidities, medical procedures, age, sex, and all of this information is run through what they call a group, a DRG grouper. And it takes all of this information and it groups it into the proper DRG number. And groupers, most health plans I've worked for, we use a grouper that's been around, seems like forever, by 3M. That happened to be the one that we always used. And we used other products from consultants and vendors that helped us with some of our DRG work. But again, most of those vendors and consultants, their software platforms use a grouper, and the majority of them use a 3M grouper. And what the 3M grouper allows providers to do, and it's considered in the industry DRG creep, it allows providers to take and play around with the diagnosis codes in such a way that it will bump a DRG to a higher reimbursing DRG by playing around with the information in groupers. And that's where individuals like me that directed a payment integrity shop at Blue Cross Blue Shield, we are trying to control DRG creep. And the way we control DRG creep is if we found a DRG that looked like it had been upcoded, it's the terminology used, but it looked like it had been upcoded, we would request the medical record, we'd request the itemized bill, and I had clinicians, nurses, that would sit down and they would go through those itemized bills, those medical charts, and we would downcode a lot of DRGs, and we saved Blue Cross Blue Shield several dollars over the years. Not only Blue Cross Blue Shield, but the employer groups that contracted Blue Cross Blue Shield for the insurance that we provided in that Buffalo market. And CMS uses a formula to set the hospital payments. And if you're interested in that formula, you can go out and grab it. It sits out there on the CMS website. It calculates the average cost needed to treat patients in a particular DRG. So it's based on averages. Base rate is adjusted by wage index for each DRG. So if the average wage index is 1, the wage index for New York City, Chicago, Atlanta, it's going to be, that wage index is going to be higher than the wage index for Raleigh, Durham in North Carolina. Or it's going to be higher than the wage index in Frankfort, Kentucky, or Columbus, Ohio. Higher cost of doing business in those metropolitan areas, so they're going to have a higher wage index. Alaska and Hawaii receives an adjustment to the non-labor portion of the base rate. Again, resources cost more in places like Alaska and Hawaii. Adjustments can be made for teaching hospitals and for hospitals that seek a high proportion of uninsured. Children's hospitals have a special adjustment assigned to it that they can use. So there's a lot of adjustments that go into based on where the hospital is located. Is it a nationally recognized teaching and research hospital? Is nationally recognized children's hospital? If it's a sole community hospital, that means a community hospital in a rural area. It's one of those types of hospitals that's exempt from DRG system. Cancer hospitals are exempt from DRG systems. So a lot of this information is being driven by these groupers, and that's the way that providers are making money on a DRG system. They don't typically have to worry about medical management because the incentive is for the hospital to admit you, provide the goods and services required to cure your ailment and get you out the door. Because again, it's a prospective payment system, and it's not really based on the number of days you're in the hospital. There are some cost outlier adjustments that if you are in the hospital and the procedure goes south, and if the hospital can treat you for less than the DRG, if they can treat you for bill charges that are less than the DRG payment, they get to keep the difference. So again, it's all based on averages. CMS calculates it based on averages, and if you're on this side of a distribution, if you're below the average, you get to keep the differential. If you are above the average, it could cost the hospital, but there are some safety nets out there for high cost DRGs. You have some what they call case mix complexities, severity of illness, prognosis, in other words, a prognosis when you get out, the treatment difficulty, the needs for intervention, and resource intensity. And comorbidities play into this, and they can include what they call hospital acquired conditions. And when you have talking about hospital acquired conditions, remember I talked about, and I guess we were talking about the diagnosis codes, that if they were pushing you down the hall and you fell off your gurney, you broke your arm. That's a hospital acquired condition. One of these hospital acquired conditions that you don't want is sepsis. If you end up with sepsis in hospital, things can go south in a hurry. And there have been some issues with patients in hospitals that have hospital acquired conditions from maybe the blood transfusion was tainted, or maybe there were some dirty needles, or there's just a lot of things that can go wrong in a hospital. And that's why most people will tell you that the last place you ever want to be if you get sick, unless it's just absolutely a necessity, is to be in a hospital. So just be aware of that. But again, the DRGs it's going to all go in with those comorbidities when it comes to calculating the DRG payment to the particular hospital. And what it means, a DRG system, what it means to healthcare providers, they talk about patient conditions and types of treatment needed. Hospital administrators, the degree of resources needed and how much they cost. And the insurance regulators, how much to pay. We're talking about insurance regulators, talking about CMS. So it is this DRG information, and there is a wealth of it out there, a wealth of DRG information that usually is it's collected by CMS at the federal level, but it's also collected on a state by state basis. So, and what you're talking about, when you talk about doing analytical work on DRGs, and I'll go back to the Blue Cross Blue Shield example. We were looking at the Buffalo market, so 7 or 8 counties around the city of Buffalo, New York, and I always knew what the DRG distribution was for individuals either in those 8 counties, and I could do it by county, or I knew what the DRG distribution was going to be for the entire population. I knew the DRG distribution for, I also knew the DRG distribution by hospital. And there were 2 huge hospital systems in Buffalo. You had Mercy and you had Kaleida. And I knew what those distributions looked like, and I could compare Mercy and Kaleida. And that's where we get into you're talking about referent measures. And I think we talked about referent measures earlier in one of the modules, but referent measures, you're just talking about if you're working for either a health plan or a provider and you have your own internal metrics, you need some kind of a comparable measure to determine whether you're doing a great job or you're failing miserably. And that's what we talk about on these referent measures. Prior to 1980s, hospital just sent the itemized bill to payers. Payers just, that's what they paid it based on. Hospitals incentivized to keep patients as long as possible. Until the DRG system was implemented, that was the incentive of hospitals. Man, they'd keep you as long as they could get by with it. Benefits of DRG is it improves efficiency, it reduces length of stay, and reduces treatment costs. At least in theory, it reduces those. It improves efficiency, again, improves the efficiency of I don't know if I said efficacy. It improves the efficiency of the treatment protocols. It does tend to reduce length of stay, and it reduces the treatment cost, at least the treatment cost on the payer side. If you're talking about a teaching research hospital, it's a little different because teaching research hospitals tend to order more tests and services. Because why? Why would a teaching research hospital be more costly? It's going to be more costly because they're training residents and interns. And the only way they can train those residents and interns is to order tests, to have them order tests and see the results of the test. And as much as anything else, it helps them determine kind of evidence-based medicine on how to rule out certain episodes of care once they get out into the mainstream private practice. And drawbacks for DRGs, especially on the patient, I'm talking about on the patient side now. You could have possibly the decrease in the quality of care. Because remember, on the hospital side, they want to admit you, they want to treat you, and they want to get you as quickly as possible out the door to home care. And some hospitals end up pushing that envelope a little aggressively, and so it could decrease the quality of care. There is upcoding on the DRG side when I talked about DRG creep, and you could, as a patient, receive a more severe diagnosis than necessary. Maybe through this DRG upcoding, it comes back and your diagnosis is more severe than it needs to be, and you may be getting a call from your health plan saying, "Hey, we see you've got this diagnosis. We need to get you into some case management type services." And you're saying or thinking, "Well, I didn't have that wrong with me." And so again, hopefully this information is going to help you when you go into the healthcare market or not. It's going to help you in your personal life moving forward. And again, when we're talking about decreasing quality of care, I'm talking about your discharge too early. Increases home care, they may try to send you to a rehab facility. And too early discharge increases what they call the probability of hospital readmissions. Medicare sets it at 30 days. They don't want to see you back in for a similar diagnosis within 30 days. Private health insurance are looking, more like, 3 to 7 days. If you're back in for a diagnosis, they're going to start questioning the hospital's billing policies. Hospital decisions are driven by what? What do you think the hospital's decisions are driven by? What are the three pillars of microeconomic thought? Opportunity cost, self-interest, decisions at the margin. Hospitals are really concerned about self-interest. They're concerned about maximizing profits. So just be careful when you go into the hospital. And then lastly, I'm going to try to talk just a few minutes about major diagnostic categories. And it's a classification system used in the healthcare revenue management. And you'll see consultants especially, they talk about RCM, revenue cycle management, to group patients with similar diagnosis for billing and reimbursement. A component of the DRG system, which is used by providers and payers to determine the appropriate reimbursement for inpatient stays. Again, the MDC, major diagnostic category, developed by CMS. There's 26 of them. There's 25 plus one that'll say pre-MDC, and that's usually reserved for things like transplants, tracheostomies. Those really high-cost services are lumped into that pre-DRG. So it'll be pre-DRG up at the top, and then it'll start through MDC 01, 02, and they'll go all the way to 25. They're grouped together by similar types of medical conditions and procedures to facilitate both research and reimbursement. So if you go through the ICD-11 book, or you get on the internet and look at it, you're going to have ICD codes changing, and I call them body systems or types of services. So, and MDCs are going to do the same thing. They're going to lump these MDCs together based on types of body systems or types of diagnosis. And within those MDCs, you're going to have all of these DRGs slotted so they fit within one of these MDCs. And as they fit into these 25 or 26 kind of the pre-med or the pre-MDC, you're going to have those DRGs falling into medical or falling into surgical categories or types. Primary diagnosis determined by the attending physician. So the physician that sees you and recorded in the patient's medical record. Remember, primary diagnosis drives the DRG, or it should drive the DRG. MDCs are assigned by matching primary diagnosis to the ICD-11 body systems and can be medical or surgical categories for each MDC. So again, this module is trying to tie together a lot of information, trying to get some domain knowledge that we hopefully will be able to use, or I'm hoping it's going to make Module 5, where we talk about the medical billing form, the CMS 1500, and Module 6, where we talk about the UB04, hoping that it makes it a little clearer as we go through and start filling out or start seeing how those claim types are populated. And then as we move on down the road, I hope it's going to provide you with the toolbox, improve your ability to function accordingly, or make you a more valuable resource or asset if you decide to go into a medical field or a medical profession. And with that, we're going to shut this module down. And next time you see me, we'll be talking about Module 5. Thank you.